Dr. Brodsky, Dr. Young, come on to the stage, Dr. Kessler. So as you guys are coming, I'm going to start with Dr. Hsieh. You said that if a patient had received gene therapy, it would be difficult to do a haplo. Now, could you collect cells and store them and then potentially do gene therapy for a patient and then consider doing I'm trying to make sure I'm asking the correct sequence of the question. So you're saying that patient who's had gene therapy, you really can't collect, right? But you could do a haplo for that patient, can't you?
I think it's a little harder to get all the stem cells first for gene therapy, store them for the future, because you really need like 15 to 20 million CD34 per kg. And I don't think the current manufacturing facilities will take frozen CD34 cells. So.
Okay. I see Rob looking at me, so Rob, I'm sure you have something to say about that.
Well, the other reason is it's very hard to give myeloablative busulfan after someone's had a transplant already. The toxicities would just be even.
Microphone.
Yeah, this is Tarek Baghdadi from Trinity Health Ann Arbor. Question for Dr. Young. Which aplastic anemia patients, if any, would you not give ATG in the first-line treatment?
Yeah, so I think time ran out. Children who have good donors should always go to transplant early, and younger adults, the age threshold is always arguable, but 40, 50. Some of it depends on patient preference, but certainly with a SIB well-matched, that's the first option. Sorry I didn't make that clear, but you'd see that if you looked at the article.
Let me rephrase. I meant you would give cyclosporine plus eltrombopag, but without ATG. Would you give that to anyone?
Right. So this preemptive early treatment protocol can lead to immunosuppression. Patient gets to a center that can deliver ATG, or tie the patient over to a transplant while waiting on genomics to come back, other testing. So the idea is to treat early, not wait around, ultimately regardless of what the definitive therapy is. We see, it was on the slide but hard to explain, we see neutrophil counts, for example, go up within a couple of weeks. And whether you're going to a transplant or whether you're going to immunosuppression, it's better to go into that treatment with 300 ANC instead of a 0 ANC, and some reduction in transfusions.
All right, Dr. Bird.
John Bird from the University of Cincinnati. Yeah, Dr. Young, the single cell data you showed was just phenomenal. And in the observation that you don't see the stem cells, the hematopoietic stem cells, at 6 months.
Yeah.
Do you think that's just because there are so few?
I think it's time,
or is this telling us that the immune system has gotten rid of them, and it's the waiting game to see when these people with the effective therapies you've shown are going to fail because those committed cells go away.
Yeah, John, I think we don't have the answer, and the next single cell experiment, and it'll probably be the only one we can do given our budget constraints, is to look at patients years down who have complete responses and relatively normal or normal counts. My guess is that they will have stem cells at that point, and I think what the data at 6 months tell us is that you can reconstitute hematopoiesis with a cell that doesn't satisfy the strict definition of an early stem cell. It's very reminiscent, it's all Sharkus and decades ago, the short-term and long-term repopulating cell in the mouse. I think we're seeing repopulation from a sort of short-term cell, and I think the patients who do well durably, but that's the hypothesis, are the ones ultimately that the true hematopoietic stem cell returns. I think but one thing that doing these snapshot experiments show you is that the kinetics are really complicated, and things take a long, for example, somatic mutation, clonal evolution takes 5 years. It's whereas chromosomal evolution occurs in months. So I think this time, sort of the usual way we look at survival at this year or overall survival, we don't really see the details of what time constitutes.
Thanks.
All right.
Luke Akerd, how do we decide, this is for the PNH population, how do we decide when we can stop therapy?
So the question is, for the PNH population, when do you decide when to stop therapy? Is that the question, Luke?
Well, or even how do we monitor for that?
You mean when you stop therapy, how do you monitor them?
Yeah, we don't have easy access to the new
Okay, so
the new
if a patient with PNH, you stop therapy, how do you monitor them?
So the PNH patients, you really can't stop therapy. There's a few where they'll have a reduction in their clone size, and maybe in them. The patients I was referring to about stopping therapy are the ones with atypical HUS. Many of them you can stop therapy once they've achieved a complete remission, but they have to be in a complete remission, and the assay that I showed you can tell you whether they're still having complement-mediated killing. So that needs to be study prospective.
But that assay is not available, or it is?
The assay is available. It's commercially available from a company called Hsieh now.
Dr. Kessler, patient, based on the data that was presented with risabrutinib, which was rather exciting, but obviously it's not available. What are you doing for your patients with relapse ITP these days?
There are many options, and they all are not home runs. So what I personally do right now, as I said, is to push the TPO receptor agonists earlier than showing failure for first-line drugs. If about a third of individuals will fail TPO receptor agonists, in those individuals, I've been using some fostamatinib, which is a Syk kinase inhibitor that inhibits macrophage phagocytosis of the antibody-coated platelet. That's been successful in about 20% of individuals. That drug, the current drug, has side effects, particularly blood pressure issues and diarrhea, as you would see in other Syk kinase inhibitors. I think I've tried to get efgartigimod for some of the patients. That works quite well, if another 30%. So you really have to play with these patients with various types of treatments. I can get daratumumab on these patients, and daratumumab works quite well as an anti-CD38 drug. So it's not one size fits all at all. I think we're going to see, now that we're looking at genomics of ITP, we'll see the heterogeneity of ITP and probably learn how to treat these individuals on an individualized protocol better in the near future.
Thank you. Dr. Brodsky and Dr. Young, I can't have both of you in the room without creating some controversy here. And your approach, the cyclophosphamide approach from Hopkins, which, Dr. Brodsky, when I worked with him, he strongly believes in and it's quite effective. And the ATG approach, which is the NIH approach, there have been some questions as to which is the best approach for these patients. I'll start with Rob. Rob, what's your take these days on these patients?
Yeah. I mean, the good thing, as Neal pointed out, is we have multiple good approaches. And I think in medicine, the biggest controversies are when you have multiple good therapies or when you have no good therapies. And so my take on it, I prefer haplo. And I do it up front because it's not just survival. Some of these patients that are still alive at 5 years are still requiring occasional transfusions, or they have symptomatic anemia, or they're still on drugs. Haplo gets hematopoietic reconstitution faster. We've gotten the 100-day mortality down to about 2%. Graft versus host disease is almost non-existent. bone marrow transplant is now cheaper than immunosuppressive therapy. So for all those reasons, that's my preferred frontline approach. I even consider Neal Young now, no pun intended. Yeah. I mean, but again, there are multiple.
What say you,
good
Dr. Young?
Yeah, so we send many patients to Baltimore, and I'm not. I think that these controversies end up, being more show than otherwise. What worries me about upfront haplo in adults is the necessity for radiation, and we can talk about being concerned, but patients got lost when there was no radiation. The dose is not trivial, and as we were joking, long-term is long-term, and I prefer not to fool with Mother Nature. I think more than 50% of patients who undergo simple triple therapy do well long-term without further complications. That number may be higher, and I think also, as I mentioned, we have now, I think, easily applicable genomic testing to say which patients are at risk for high-risk clonal evolution, which is the real worry. There is this group of patients who are kind of borderline, and you worry about relapse, and sure, we consider haplo for them, but some of those patients will do well indefinitely with a second round of immunosuppression avoiding transplant. So I think it is, fortunately, in the age of machine learning and AI, it still requires some human clinical judgment as to which is the better route for the patient and when.
Thank you. And then before we go to break, Dr. Kessler, should I continue to lower the dose of doax after 6 months of anticoagulation, or should I be scared of that small risk of increased thrombosis?
It's a great question. I think the studies show us that for most patients, you can dose reduce, but I think you have to look at other comorbidities. I think that if the patients continue to be morbidly obese, I think if they have thrombophilia genetics, like factor V Leiden or prothrombin gene, I think that I would probably maintain full dose in those individuals, but for the routine patient, I think you can dose reduce.
Thank you so much.